So welcome everyone. Today we have Dr. Tatiana Haverluk. She's an emergency physician and founder of Hello Sono with 15 years of experience using POCUS in diverse settings from urban EDs to Everest Base Camp. She is dedicated to extending its benefits to more patients. With Hello Sono, she and her team support practices in building compliant, high quality, and profitable POCUS programs through tailored education and implementation. Today, we have a case. This podcast is entitled No X-ray, No Problem. POCUS Diagnosis Pneumothorax in a Rural Setting. So, Dr. Haverluk, take us through this case.
Hello, Randy. Nice to be back. In this case, we have a 25-year-old man who developed sudden chest pain while walking, and he comes into a rural clinic. And his vitals are normal, but he's still complaining of pain. The clinician examines him. His lung exam is normal as well. His EKG is normal. But what is the one thing you really don't want to miss? So the clinician performs an ultrasound, and the image they obtain is the one actually on our screen's right side. And the normal is shown on the left, just for everyone who's watching this. But basically, on the right side of the screen, we are seeing a lung ultrasound where the top of the screen is just soft tissue and muscle, and then there is a bright white line that we are seeing, horizontal line, correct? That's the pleura. And what's interesting here is on the part of the screen, so on the right side of the screen, it's moving back and forth and there's shimmering. And on the left side of that image, it's not shimmering. No, that specific image that I'm referring to, patient's image. So this is actually called a lung point, and this is the exact spot where pleura separates, the visceral and parietal pleura separate. And this is really 100% specific for a pneumothorax. So once the clinician identified that this patient has a pneumothorax, obviously it changes management and it escalates what you are going to do for this patient. On the left side of the screen, we are seeing a normal lung. So here we're using a slightly different probe, so you're getting more depth and field of view in this image. But basically, the top bright white line or hyperechoic line, horizontal, that's the pleura. And there's a little bit of shimmering. It's also called ants marching, but there is constant slight movement of that line. So that tells us that the parietal and visceral pleura are moving up against each other, and there's no pneumothorax. In addition, what you are seeing on the left side of the screen is there's a repetition of that horizontal line. That is normal. Those are called A lines. That's an artifact that happens when the lung is air-filled. So we are actually seeing A lines on both sides here in the normal and abnormal image. And we're also seeing the black vertical kind of areas on the sides of the lung, and those are the shadows from the ribs. So often you want to identify those first to make sure you're in the correct place.
Excellent.
I think that concludes our evaluation of these images, but we can keep talking about lung ultrasound and pneumothorax.
Yeah. So, how does POCUS compare to chest X-ray and diagnosing pneumothorax? Just kind of compare the two.
Great question. POCUS is more sensitive and a lot more specific than pneumothorax, especially if you identify the lung point. But the sensitivity of POCUS is in the 90s versus for chest X-ray, especially if you get a supine chest X-ray on a trauma patient, say, it can range from 47% to 70s. So really, the chest X-ray is not the greatest choice in diagnosing pneumothorax, especially if they are smaller ones. So a lot of times I worked in the ER for a very long time, and a lot of times we'll get trauma patients who we perform a chest X-ray on, and it's supine and it's negative, and then you get a CAT scan and they're pneumothoraces at the APCs. So ultrasound is just better.
Yeah, and I would imagine it's a little quicker to get the information.
Yep, 30 seconds.
Yeah.
And one thing I didn't mention is the location where you want to look on the lungs. So remember that the air arises. So actually, the easiest way to identify a pneumothorax would be at the anterior apex of each lung. So you will just look at the second intercostal space, midclavicular line, the exact place that you would do a needle decompression, for example. So very quick, you put the probe in a sagittal orientation, you find your pleura, you look for shimmering, you do it on both sides, you are done.
Yeah. So a lot faster.
Yep.
So why is the lung point so important? Talk a little bit about that.
Well, one thing I mentioned already, it has really multiple studies have found it has 100% specificity, meaning if you find it, you have confirmed a pneumothorax.
Yeah.
Another cool thing about it is depending where on the patient's chest wall or thorax you find it, it can tell you how big the pneumothorax is. So if you are getting it really close to the apex, it's a tiny little pneumothorax. You might be not rushing this patient to the ER necessarily. However, if you find it further down on the chest and more posterior, it tells you that there's a significant lung collapse, and this patient might need a lot more care sooner and decompression.
Yeah. No kidding. So, why is lung ultrasound such a high yield skill for rural and primary care clinicians?
Well, just like in this case where the patient was otherwise healthy but might have a really devastating diagnosis that's life-threatening, when you perform an ultrasound, you can either rule it out or rule it in, right? So in this case, it was a pneumothorax. In other patients, you might be looking for congestive heart failure, you might be looking for a pneumonia, right? And all of those are significant diagnoses that can allow you to manage patients right away. You're definitely avoiding that delay in imaging, or even like some patients might not follow up right away. If you're in a rural location and this is maybe someone who's managing a farm, has a lot of things to do, he might be ignoring his chest pain until, it really gets bad, and then he'll go to get imaging. So I think this is really a great tool to get this things done started at the bedside.
Oh yeah, and it's the same thing we always talk about with POCUS is that if you have the skill, 30 seconds, and you know what you need to know, and you can take care of what needs to be taken care of rather than say, oh, we'll come back tomorrow or the next week or whatever. Yeah, it's just the quality. It's just, once again, the quality of POCUS compared to some of the way things have been done, previously. It's just, if you have the skill, you can really make a difference. So, once again, very interesting case. I love the fact that we use some images in our podcast this time, and look forward to our next case. What do you have coming in store for us in the near future?
Well, I wanted to actually tell you about a POCUS workshop that we are going to be conducting basically at the first day of the SMA conference and Zaruka conferences. So that's going to be on November 13th in New Orleans. It's 4 hours. It's really geared toward primary care, urgent care clinicians. And we're going to be covering a ton of good stuff, including lung ultrasound, DVT, soft tissue, musculoskeletal, renal. So I really hope we get a good turnout. We have great instructors. So yeah, come to hellosono.com to find the registration page and register.
Yeah, and so if anyone's interested in attending New Orleans in November, it'll be a fantastic time. Get some hands-on experience, and visit hellosono.com, or you can email SMA at education@sma.org, and we can get the information to you. So thanks once again, Dr. Haverluck. It's very interesting.
Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.